Hello, everyone, and thank you for joining us for this webinar, Recovery to Practice webinar this afternoon. On behalf of Substance Abuse and Mental Health Services Administration and the Recovery to Practice team, we'd like to welcome you all and thank you for joining us. We have over 70 people joining us today, and we know that that number will grow as we begin to move forward into the webinar. My name is Lori Curtis, and I'm your host for this afternoon. After some brief housekeeping and a short review of Recovery to Practice, we will begin today's presentation. At the bottom of your screen, you will see a Download Materials box where you can access our presenters' bios as well as a PDF of the presentation slides we'll be using today. This webinar has been pre-approved for continuing education credits through NADAC, the Addiction Professionals Association. To qualify for these continuing education units, you must attend the full webinar, complete a short quiz at the end of the webinar, and complete an evaluation of the webinar. More information about this is at the end of today's webinar. Finally, if you are registered as an attendee, you will be emailed a link to view the archived recording. This link will be also available on SAMHSA's Recovery to Practice website. This webinar series is hosted by SAMHSA's Recovery to Practice initiative. The overarching goal of this initiative is to improve the knowledge and ability of the behavioral health workforce to use recovery-oriented practices every day. Understanding what recovery means is critical to our and their success. SAMHSA's working definition of recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Recovery to Practice offers a set of discipline-based curricula to promote the understanding and uptake of recovery principles and practices. Developed by 6 professional disciplines for educating their own membership about recovery and behavioral health, these materials are available and adaptable for use by other disciplines and organizations seeking recovery resources to build their workforce. Recovery to Practice can help you strengthen your recovery-oriented practice through these free webinars, newsletters, training, and technical assistance. Check out the Recovery to Practice website regularly for new opportunities. This particular webinar today will explore and expand perspectives on what is shared decision-making and what is the shared decision-making process, and provide strategies that can and examples of how it can be adopted by a variety of practitioners in diverse practice situations. I'd now like to introduce our speakers for today. Our first speaker is Jacqueline Pettis, an advisor and trainer with the Recovery to Practice project. In her current position as Manager of Wellness and Recovery, she provides leadership for wellness and recovery at Beacon Health Options in Maryland, the nation's largest independent behavioral health company. Prior to that, she led Baltimore's behavioral mental health service systems, the core service agency and local mental health authority for Baltimore. Our second speaker this afternoon is Melody Reefer, a Senior Program Manager at Advocates for Human Potential. Ms. Reefer provides consultation to behavioral health authorities on many aspects of recovery-oriented systems. During her more than 30-year career, Ms. Reefer has worked as a practitioner, a manager, educator, and consultant.
Hello?
Hi, Jackie. Please feel free to go ahead.
Oh, yes, I couldn't hear. Oh, hello, everyone. Good afternoon. I'm going to start out in looking at the overview of shared decision making. 1 second. And shared decision making is an interpersonal and independent process. 1 second here, sorry. It's an independent, interpersonal independent process, and it's a partnership between at least two people. And for the sake of our discussion today, a healthcare provider, as well as the person that's in treatment, there's a collaboration in making decisions about treatment. Together, people work on building a consensus and relies on medical evidence, experience from the person, expertise, preferences for clinical and non-clinical staff. And there are specific unique characteristics of the person in treatment. Key components of shared decision making. Key components of shared decision making are listed here: information, education, responsibility, values, preferences, and respect. Seeking a balance between the perspectives that influence decision making, mutual education and mutual respect, and responsibility for decisions, respect for decisions once they are made, and treatment focuses on what matters most to the person. And we can involve family and other natural supports, of course, with consent. Some barriers to implementing shared decision making. 1 second. Some barriers to implementing shared decision making is perceived time constraints. Healthcare providers' views regarding which people want to participate in shared decision making, which people should engage in shared decision making, and who are capable. And there's a belief that shared decision making only applies to physicians and others who prescribe medications, but we know that that's not necessarily the case. There's also a lack of training is seen as a barrier for providers, and also the person in treatment lacks information and skills to participate in shared decision making in a meaningful way. So the lack of training also of advocates to describe and help people prepare for the process. We have a poll here, and we're going to ask, what do you think is the greatest barrier to implementing shared decision making? And you could see a poll below at the bottom of the slide, and you can just take a quick vote and see what our audience thinks about that. And it looks like with the polling, well, there's a change in the time constraints. Looks like people online are seeing time constraints as the biggest barrier, which is consistent to what we often hear from people in the field. So that looks like time constraints. Okay, next slide. Perceived time constraints. Perceived time constraints is the most frequently cited barrier to implementing any change in clinical practice. So that's really not a surprise that we have these findings, but then combined results of several randomized trials provided there's no strong evidence that more time is required to engage in shared decision making than it is to engage in any change in clinical practice. So it's important to emphasize this when talking to staff and trying to encourage people to participate in shared decision making. And also what's been found to be helpful is the early identification of champions within the organization, people who believe in shared decision making and the effectiveness and the improvement in outcomes of care. And as we mentioned before, training is important, and teaching both the providers and the people receiving services how to communicate in a different way to help them to implement shared decision making. And we need to create time for dialogue to collect routine information up front, which can save a lot of time. We also know that the use of technology is an important way to save on time constraints. Use of technology, smartphones, electronic records, electronic medical records are ways that people are overcoming some of the barriers to shared decision making. Other examples include providing real-time training and coaching, because people need ongoing support when you're implementing change, whether it be shared decision making or other types of change in clinical practice. And there's several decision-making aids. There are several decision-making aids that people use to promote and engage in shared decision-making and to create dialogue, provide relevant educational information. Let me come down here a bit. Provide relevant shared decision tools, provide training, mention that, real-time coaching, discussing advantages for staff and persons, and those including improved relationships, better follow-through on treatment when people are involved in the decisions that are made in the clinical treatment. So there's several different things we can do, and most people are familiar with decision aids because there's many that are out there and available. And as I mentioned about making technology your friend, smartphones are used a lot. So here's a list of who is, when people think about who's involved in shared decision making, we have listed here a variety of team members, and also we recognize that shared decision making occurs in a variety of health services, peer-run programs. But who do you think is missing from this list? We have several team members here, but in thinking about who's missing. Well, the obvious person that's missing is you can't do shared decision making without the person that is receiving services being present, seen as an equal member of the team, and being effectively engaged in the treatment process. I wanted to share just some of my personal experience with shared decision making. One of the things that's important to me in preparing for health appointments of any kind is I try to have some questions that are ready, and some of the questions that I have here is that, is the treatment necessary? What are the costs involved in terms of, does insurance pay for certain things when recommendations are made, and what impact will it have on my life personally? And we sometimes will talk about with these options, what are the risks and benefits, and what I do in my relationship with my providers is try to be as transparent as possible. And sometimes in looking at, say, in the example of medication, it says here what's the science behind some of the recommendations, but just simply means in looking at, is there evidence for the recommendations that are being made? Because sometimes that gives me a better sense of security. The other thing is having tools and support. And I think one of the tools that I use the most for myself is my cell phone. I use my cell phone to set up reminders. I use my cell phone to follow up on notes of what we've discussed in the appointments or things that I need to explore and get more information about. I ask for input, and I get a lot of support from my friends and family. Some people use tracking forms, and I've used them in the past. I use personally a journal that helps me follow up on some of the things that we have talked about in the appointments with my healthcare providers. And of course, peer support is very important. People that can understand and relate to the specific healthcare issue that I am dealing with at different times, and I think that's critical. And again, the decision aids can be as simple as having a pro and con cons list of what some of the recommendations are that are being made, or they can be real complex and using web-based decision aids. And there's a number available, and you can just simply search online and find others that will fit you and how you engage in shared decision making. The other thing for me in the shared decision making with my providers, and I'm pleased to say that it's really been effective, and it's changed my whole outcome when it relates to treatment and getting and advocating for myself. So I spend a lot of time preparing in advance, because we do know that in order for me to get the best out of the appointment, it is necessary that I make the best use of my time and the best use of the time of the provider. And we engage in honest dialogue. It's not a conversation where I'm telling the person what it is, what I want them to do only. We really do have a conversation and a relationship. I think shared decision making is based on relationship. There's no pressure to accept recommendations, and there are times when I have disagreed with what my healthcare provider is recommending, and that's okay. What we've done in those situations is we negotiate what the options are, and I'm fully aware and responsible for whatever choice that I make, whether we agree or disagree, and that's what's nice about shared decision making. We each accept responsibility, the entire team. And I usually leave the office feeling that there's respect for me and for my particular decisions that I've made, and also that I have respected my physician or my other healthcare provider. Now I'm going to turn the presentation over to Melody.
Hey, thank you, Jackie. I sure appreciate your knowledge and information. In particular, I appreciate your weaving in information about your personal use of shared decision-making processes. I want to begin by telling y'all about one of the things I have encountered when learning about using and teaching about shared decision-making. And I think it's helpful to start, where is it that we begin in our normal process with our care providers? And so I imagined, what if these appointments were on the telephone instead of in person? And I imagined there being a lot of silence, and that a lot of the information that that we think we're sharing actually stays in our head, that it's just thought bubbles, if you will. And so I could be sitting in the appointment and having these concerns, maybe saying, this medicine's causing me to gain too much weight, or I'm having a hard time waking up in the morning. I don't know how to work around this grogginess, or, you know, my sex drive is 0 and it's negatively affecting my relationship. But they're just thoughts in my head, and my provider, for as much as I know, is sitting over in their chair thinking, well, you know, I guess things are going okay because you're not hearing voices. You know, oh, I don't really want this person to work because I think it's too stressful. Or, oh my gosh, I can't believe I've got so many people still to see today. I'm running behind. And these are all these thoughts that are happening in the appointment, and they get in the way of our ability to do any shared decision making, because it's just thought bubbles. And so one of the things that we can do with shared decision making is move from thoughts to actually speaking with one another. we think we already do shared decision making. I had a nurse practitioner once literally say to me, I do shared decision making. I care so much about the people that I work with and that I see. And so I make a decision and I share it. And she didn't hear how weird that was, that was not what shared decision making is. And so I think this visual, if you're in a place where you can see the screen, points out some really important pieces to what we need to consider for shared decision making. And that is that there are some common factors that are influenced by a person's perception of their level of involvement and the person's trust in the clinician or care provider, and then the person's preferences for the level of involvement that they want to have. And all of those feed into the person's comfort level with shared decision making. And so it's important that we give that some thought, but we can't stop there because this very same process is happening for the clinician or the care provider. And so the clinician has their perception of involvement feeding into the shared decision making, and their trust in the person feeding into shared decision making, as well as their preference for involvement, either a preference for what their level of involvement should be, or their preference for what the level of involvement for the person they're serving should be. But this is happening on both sides of the process, and and all too often when we're looking at training or implementation, we only address one part of the dynamic, one part of the pair for who is influencing the shared decision making. So there are some great training resources around shared decision making that we have a responsibility, I think, to make sure that people have access to. And I'm a big proponent for having all information available to everyone. And so even though some information that you find will say, okay, this is geared towards the prescriber, or this is geared towards a case manager, or this is geared towards paid staff, and here's a brochure for a person receiving services, I think that everybody should have access to all the same information. And that's one of the reasons why Recovery to Practice is such an important initiative in the way that it brings together people and disciplines and cross-educates folks as they are pursuing recovery-oriented services. So this is labeled 5 core components of shared decision-making to be facilitated by the clinician. And this facilitation is that whoever the provider is in the moment for identifying a shared decision-making process, that they have some responsibility to take this on and to really help jumpstart the process. I fear that in trying to provide recovery-oriented services and in trying to be person-centered, that has led some providers to believe that they should step back and and be hands-off and kind of let a process go on organically. But I really think that there's a mutuality in the responsibility for recovery. That if there's something that I know as a provider that I can share with somebody to help them move this towards being more recovery-oriented, then that's going to be helpful. And I want to leave room for the person to teach me, and it's really this co-teaching, co-learning relationship development that is really foundational for shared decision making. So let's look at these core components. If I'm trying to be of assistance to someone, and I'm trying to nurture an environment where shared decision-making can happen, I'm going to say, and I'm going to be thinking, I want to seek an agreement on the decision to be made. That doesn't mean that's where we start, but it means that's where we're trying to get to. And it doesn't even have to be agreement on everything. So even though, for instance, in a relationship, I might agree, a real-life example. Last night, we were talking about dinner, and we couldn't agree on how to get it done, but we could agree that we wanted Chinese food. And so that place of agreement helped us leverage a next step. And that was shared decision-making. If we had stayed in the place about, just talking about what we disagreed on, like how to get it done, I'm not going to cook, well, I'm not going to cook, and that difference, it wouldn't help us move forward. But if what we were pursuing was where can we land on an agreement and help move forward from there, then we can really get some momentum. A second core component is providing information and access to decision aids. Someone mentioned in the chat earlier about Medline Plus. Medline Plus is actually not a decision aid, but it is a place that provides information. And it's a place that has some level of integrity because it's not based on advertisement. Whereas some medical information sites that you go to are the way their business model, if you will, is to take advertisements, and so that sometimes you can't differentiate the information that you're seeking from an ad. And so as a clinician or as someone partnering with another in making a shared decision, I want to make sure that I'm providing reliable and vetted information, or at least making sure that it's available, and also making sure people have access to decision aids. There's a whole institute, an international organization that oversees and defines what constitutes a decision aid. And so it's not just simply saying, here, let me help you with a decision, but it is, it's like, so let's explore all the sides of the issue. Let's make sure that someone has had access to reliable information, and let's give time and space for exploring the person's ideas, concerns, expectations, and values. And that component of really giving some weight to what someone values and what their preferences are is an absolutely critical part to shared decision-making. And unfortunately, it's one that is frequently swept under the rug. that what I feel about the medicine I take, or what I believe about a particular intervention that I want or don't want, doesn't seem to influence the process too much. And in shared decision-making, we're saying, as we adopt this practice as a universal practice for our services, we will take into consideration, we do care about what you feel and what you think. Another important part of shared decision-making is capturing the decision or the decisional leaning. And so the idea of capturing the decision, it's not just doing a note for a billing purpose, but it really is saying at this point, at this particular crossroads, we decided as a team or as a pair to go in this direction. And part of the capturing is so that we can then go back and review the decision to see if it actually worked the way we hoped it would work. So in order to review something, you have to kind of remember that you did it, and you have to move it up to a conscious level. And so shared decisions aren't accidental. And you can't go back and say, oh, that was a shared decision, because there would be a lack of intentionality with that. And so being intentional, marking the decision, and even having a plan for how you're going to review it to see if it works. So when I see my doctor, and we're talking about medications to help manage my diabetes, every single time, part of that decision is based on how long are we going to try this medicine, what do we hope it will do, and when will we review its benefit. And my doctor knows that I'm going to be involved in this, that it's not just waiting for a test to come back, but that it really is more of a process for both of us. And so he can share with me what he's learned from other people. I can share with him what it's like for me. And we both teach and we both learn. That's a bunch of information, but all of those steps really are important. And we're making some inroads into having some people who provide behavioral health services become aware of what it means to do quality shared decision-making. But there are also factors that influence the person's participation. So if I am a service recipient, how I interact during the shared decision-making process really is going to influence how that goes. Do I have the confidence to speak up? Do I have experience with speaking up? Some of us have received services where we've been encouraged to not speak, and I'm using the word encouraged kind of as a polite term, but where our silence has been preferred over our speaking up. And so to change that behavior, to move into a environment where speaking up is not only allowed but is expected, is a really big change. In doing so, though, there are some vulnerabilities that are created, and if I talk, then I become more vulnerable around how people are going to see me, and what their perception will be of me? Will they think I'm not smart? That I don't know enough about my diagnosis or about my history? Will they? Will I receive or will I give misinformation about mental illness or addiction? If I'm working with somebody who is not an expert, or if somebody's working outside of the realm of their expertise, then that creates a vulnerability for me. And so I don't want to take medical advice from someone who doesn't know about medicine. I don't want to take housing advice from someone who's always had information or resources provided to them. That there's something about being able to rely on somebody's having walked through certain paths that makes this an important process. My previous treatment experiences also influence how I'm going to be involved with shared decision making. If I've always been told what to do, or if I'm angry because of the way I've been treated, and so I am not engaged in, I don't want to do shared decision making. It's like, I'm not going to share. This is my decision. And in doing so, I kind of limit my access to reliable information. The other thing that is a vulnerability is limitations that are put on us by external forces. So poverty, ongoing health problems, lack of education or access to educational resources, lack of transportation, all of those things that are external of our will, that are external of our desires, are still going to really limit what we can say yes to or no to when it comes to shared decision making. And so that's important. And then having limited support and or limited relationships. If I'm alone in this, but the shared decision is, do more social things with people, that's not really helpful, because I need some steps before I can go to that shared decision, before I'm a piece of that. How to make friends, where to reach people if I'm poor or don't have a ride, how do I interact with folks? And so we have to really appreciate the place where someone is emotionally and physically and socially when we're working together to find points of consensus and ways to move towards a next step. There are influences for the care provider's participation. And I spent a good number of years in my recent past being responsible for training psychiatrists and other care providers in using shared decision-making in their practice. And some people were just like, oh, this is fantastic. I remember this one psychiatrist in Pennsylvania who was like, I am so thrilled with this tool. I've felt these things. I've had it floating around my head. I know that relationship is important, but shared decision-making gives me the structure and the vehicle for doing so much better in my practice. And so, I'm thinking, wow, that makes me a really good trainer because she got it. But then there were other people in the room with her who were just like, am I going to get a CME for this? Or I got to go, I've got an appointment, folks who are just not engaged. And so people have different responses based on who they are, and that supersedes kind of like what they are. So whether they're a nurse or a psychiatrist or a residential provider, that's just their title, but who they are influences how they respond to shared decision-making. So do they have communication skills? Active listener. You wouldn't know it by the way I'm talking today, but I can actually be a good listener. Given the way webinars work, I have to talk a lot, but I learn so much when I'm sitting back and listening to someone or with someone. Using language that people understand. We've got to throw away our technical jargon or our professional jargon. It's not helpful, and it gets in the way. But some providers feel much more comfortable when they're speaking with authority or using big words. Positioning ourselves as equals. And I can't say enough about how important that is in any human relationship, that, being able to take turns as who's the teacher and who's the learner, that we all are coming from the same place, providing an array of choices and sharing your story about how you became an expert is as important as sharing your story about how you've reached your point of recovery. Believing in your principles and working your principles. In 12-step vernacular, that's you gotta walk the walk and not just talk the talk. And so that's being person-centered and strengths-based and embracing resiliency and being open and honest, and all of that is so critically important. So we've got the person who influences shared decision-making. We've got the provider who influences the shared decision-making. And we also have other things that influence it. So the system influences it. And so that's both the mental health system, but the community at large. Do you have enough staff? Do you have enough time? And so much of this is driven by people who aren't thinking about shared decision-making. They're thinking about resource allocation. And somehow the two have to spend some time together and know that an investment up front in establishing a good relationship is going to get you further and much faster. So making room for shared decision-making to happen. And then having the societal and cultural factors be considered. If a person grew up in a culture where it was a sign of respect to not interrupt or share your opinion with an expert, then that needs to be addressed. And the definitions for the relationship need to be expanded so that you're responding to the person's cultural orientation, but also inviting a different type of relationship. And there would be a gazillion examples of where culture influences this. But those are things to consider as we move towards shared decision-making. And then finally, I just want to wrap up by saying that shared decision-making is not about medication or who is involved in the decision, but it really is about making and involving yourself in shared decision-making across the system and across relationships. It's not reserved for the med clinic. It's not reserved for a peer relationship. It happens with all of those relationships and in all of those settings. So I hope that information is helpful for you, and I want to turn this over now to Lori, who will guide us through an opportunity for some questions and discussion.
Hi, everybody. Thank you, Melody and Jackie, so much for those presentations. I think I know a lot about shared decision-making in behavioral health. And then when I listen to you guys, I realize, you know, I've got a lot to learn too. And that's wonderful. So thank you both for taking the time with us this afternoon. We do have a couple of questions, and I'd like to share them with you. I'm not sure who I should ask this particular question of first, so I'm going to toss it out, and whoever feels they've got the best answer, toss it out. So that is, there's a question about shared decision-making and peer providers, and how peer providers can get some training and then integrate shared decision-making into the work they do with individuals. I mean, is this even the job of peer providers? How does it work with peers, and where can people get trained?
Melody, I can take this question.
Sure, Jackie.
I think that training is available and can be available through the employer. I think those programs that have begun to recognize the value of peer support when providing training for other members of other team members that are involved in the treatment team, it is important to recognize, as Melody has said, and we've pointed out throughout this particular webinar, is that everyone is involved and has an opportunity to participate in developing a relationship. So certainly the role of peer support staff in working with the person, it's just as important that those relationships are developed, and within those relationships there are opportunities to engage in and support the person in shared decision making, and then even advocate with the person's permission back to other people that may be members of the team. But I think with training that's traditionally been offered to members of the team, it's important to point out that peers need the same, not the same training, but peers need training as well, because this is a new skill set, as we talked about earlier, in learning how to communicate, learning communication behaviors that support shared decision making.
I agree with everything that Jackie said. I would add one more thought, and that is I think that certification programs for peer providers need to incorporate a module on shared decision making, so that as people are looking at how they interact with folks and provide services that are respectful of the peer relationship, that they also know how shared decision making can happen in that. And where people are already certified, I think it's a great post-training topic. And of course, with recovery to practice resources and brass tacks resources, both of which can be accessed through the SAMHSA website, there are some really great recordings of webinars and resources. So even if your provider is slow on the uptake, you can take on some of that responsibility and find the information that's available.
And thank you, Melody, for adding that. And I want to point out that next week's webinar, which will be the last in this series, will also take a look at some of the ways that peer programs themselves are embracing and using shared decision-making within their own services, and ways that they can help people in a somewhat formal way, but in a structured way, to prepare for meetings with physicians and things like that. So that is this coming up, and we will be able to dig in a bit. I've got another question, and that is, one of the things, the topic of this webinar is about it's a process, it's not a program. And yet a lot of shared decision-making has somewhat been program-focused, and that's the same in healthcare as it is in behavioral healthcare. When I had a health incident, I went to the Shared Decision-Making Center. They mailed me, booklet decision aids. I had appointments with different types of physicians and a coach to help me make a decision. I mean, there was a structured program. When we deconstruct from that with specific tools and specific processes, we begin to get fuzzy and confused. So could you, perhaps Melody, elaborate on what's the difference between shared decision-making as we're presenting it here and something like really good quality person-centered care? Is it really the same thing? Is it new? Is it different? Is it can you help me?
I hope so. The way that I think that it's different is that there are some, let's say, milestones that one follows in shared decision-making that takes it a step beyond just a principle or a theory and moves it towards a process, but a process is not the same as a program. So a process can be applied in lots of environments and in lots of situations. So the process of shared decision-making can take place in education as much as it can take place in the business world, as much as it can take place in behavioral health. And that is the process, I think, in really, really simple ways, defining the decision point, exploring the factors that influence what you need to make the decision. So whether it's more information or time or research, and then sharing opinions, because shared decision-making doesn't happen in a vacuum. I can't do a shared decision with myself because I would be dishonest. And I know, but I think most of us would. That it involves that other person who helps us think more broadly, and then weighing that with how it fits in our life. So that's kind of the first part. So the decision, the information, how it weighs in our life, and then there's where's the agreement? What are we going to try? Whether it's for a long time or a short time, and then the assessment, and then keep it on again. So it's a cycle that moves forward with lots of different decision points coming up, but I can do it anywhere with anyone. I've taken shared decision making into my personal relationship, into my home. So that when we're, it's like, oh, this would be a good time to actually add this process. And it's helpful.
I'm going to expand on that. We've got a very interesting question that's come in. And maybe, Jackie, you want to take it, share your thoughts first, and then we'll let Melody respond as well. And that is, how does shared decision-making work in settings where people are receiving involuntary treatment?
Well, I think even in inpatient settings where people are receiving involuntary treatment, there are always opportunities. They don't have to be large opportunities, but there's always opportunities in that relationship where a person should be given the opportunity to participate in the decisions that are made about them. So say if there's been an involuntary commitment and the person is advocating for what it's going to take for them to be able to be discharged, in that relationship with their healthcare providers, there are opportunities to ask the person what they think they need to do in preparing them to go before, if it's the judge or the judge or the body of people that have the authority to make that decision. It's important to ask the person and help them see, guide them in that they do have some say You may have been involuntarily committed, but everyone's goal is to help a person get back into the community with their lives. So people that are a member of that particular treatment team and family with consent and people that the person trusts can help that person identify and encourage that person to identify where they can make some decisions, where there are opportunities to make a decision. I don't know if that's clear, but I'll let Melanie pick it up from here.
Yeah, that was great, Jackie. I think that whether you agree or not with involuntary commitment, the goal for those of us who believe in recovery is greater autonomy, and so pulling in shared decision making at every opportunity, just like Jackie said, helps to move towards obtaining that goal. Because a decision was taken away, or several decisions were taken away, doesn't mean all decision making capacity was taken away. And so I think it's even more important that people, care providers and folks in services, receive education about shared decision making.
Thank you. I think those are both really rich comments, and I'm going to throw in addition to that, if I may, with both of your permissions, and that is I think part of this is about the parameters. And sometimes there are parameters for any decision. There's things we can do, there's things we can't do, and we need to make decisions within those parameters. And I think in a lot of settings that as clinicians, particularly, we need to be very clear on what the parameters are. There might be something I want that simply isn't available or is entirely inappropriate for my situation. In other words, taking an aspirin for, my appendicitis. I mean, they're just things that, there's parameters here, and understanding those parameters of any decisional set and working within those. And I think part of what you're saying is how do we use shared decision-making within the parameters that are available? And if I'm in involuntary care, there's some parameters there.
Absolutely, and I think that that's a part of the that information gathering section of shared decision making. That it's that where you explore and identify what the parameters are.
Yes. All right, and at this point, I am going to close off this rich conversation. I want to invite everybody to be sure to join us for the next webinar next Tuesday, same time, same place. And I would like to also let you know that both Jackie and Melody are available to talk to you if you would like to follow up with any conversation or ask some specific questions. They're both exceedingly knowledgeable. I would also like to let you know that we have coming up our next following webinar, but after that in September, early October, we will be doing a webinar on psychiatric advance directives, and we're really excited about that. We've got a wonderful lineup of presenters. This will be the same topic as the next Recovery to Practice newsletter, which should hit your mailboxes in early September, right around September 7, also on the theme of psychiatric advance directives. So these two will go hand in hand, and we think they are wonderful and exciting, and we encourage you to register when that announcement comes out. I would like to also let you know that you can, if you're interested in NADAC continuing education hours, please click the NADAC link here, where you will be going directly to a page with a brief quiz and an evaluation of this webinar. Completing those, you will receive your certificate. If you do not need NADAC CEUs, you can still download a certificate in the materials box near the bottom of your screen. Also be sure to complete the feedback questions that will load after the end of this webinar. We really, really, really do appreciate any feedback you provide. Those evaluations are important to us, and we take them very seriously. So on behalf of SAMHSA, I would like to thank you for taking time out of your day to attend today's webinar. And this concludes our call. Please have a great afternoon. Thank you.
Thank you.
Thank you.